Hello, everyone. Thank you for coming to our presentation on direct prediction of clinical management bypassing AI-based diagnosis application to skin lesions. I'm Kumar Abhishek, and this is a work with Dr. Kawahara and Professor Hamarni from the Medical Image Analysis Lab. So we begin by looking at the traditional medical image analysis pipeline. It starts with imaging, with which we get medical images, which we then segment to extract segmentation-based features, on which we perform a classification and then finally decide on the management. So how this looks like for a skin cancer scenario would be, we have a device known as a dermatoscope, which is used to acquire images of skin lesions. We then segment those lesions and extract features from those lesions to classify the lesion. In this case, if it's a melanoma, we decide that we need to excise the lesion. So in this paper, we asked the question, why should we predict management decisions? First off, management is the ultimate task, and in a way, diagnosis can be thought of as a latent task. So it's better to dedicate the model's capacity to predict the management decision itself. Next, multiple diagnosis categories are managed or treated in a similar way. And finally, it might be the case that images may not have enough visual information to perform an accurate diagnosis. And this is in fact the case in real world where dermatologists request a biopsy to confirm their diagnosis. So in the past few years, we have seen the deep learning based diagnosis of skin cancer has become quite accurate. We have these papers in the last 2, 3 years, which show that they are performing competitively when compared to dermatologists. And so if we modify the pipeline a bit, we have images from which we predict the diagnosis. And then if there exists a diagnosis to management mapping, we can then infer the management. So for example, for these lesions, we can have a mapping, say if it's a melanoma, excise the lesion, if it's a nevus, follow up, and so on. In this paper, we try to directly predict the management decisions, which means given an image, we directly predict the management. So for this case, given this image, we directly predict this, that this lesion should be excised. So here we work with the interactive atlas of dermoscopy dataset. We have 5 diagnosis classes, these 5, and the underlined ones are the malignant categories. And for each lesion, we have one of 3 management decisions. Those are essentially that the patient should schedule a follow-up visit, the lesion should be excised, or there is no need for any further examination. Uh, Here is a snapshot of some images from the dataset. The variability of images shows how difficult it would be to accurately deduce the diagnosis itself from the images. So how do we infer management decisions? Imagine we have a set of probability vectors for the predicted diagnosis. We can either take an argmax, choose the most likely label, and apply this binary mapping where we excise the malignant lesions and do not excise the benign ones. And so this is the mapping for these disease categories. Or we can take a more sophisticated approach using prior probabilities where we take a weighted average based on the diagnosis management priors, and then we infer the most likely label using prior probabilities. So when we compare the predicted and inferred management decisions, we see that the predicted management decisions are closer to the ground truth. We plot here the test cases for 4 different distance measures. The red points denote the directly predicted management decisions, and the blue point indicate the inferred management decisions. And we see for all 4 of the measures, the directly predicted management decisions have a lower error. Next, we look at the confusion matrices. Again, we see that predicted management decisions on the right-hand side are more accurate across all the classes, whereas inferred management decisions tend to over-excise the lesions, as we see here in the rightmost column. Next, we want to evaluate models' generalization capability. For this, we'll look at another dataset, the melanoma classification benchmark dataset, and we take a pre-trained model from the previous dataset and apply it to this. This dataset has 100 images and 2 diagnosis classes, melanoma and nevus. Melanoma, as we said, is the malignant class. And for each lesion, we have a management decision, that is whether the lesion should be biopsied or treated, or whether we should do nothing about this. But the interesting part about this data set is that for each image, it has the clinical management recommendations from 157 dermatologists from Germany, around half of whom are board certified. And we use the aggregated opinions of dermatologists as the ground truth. We see here that again, the predicted management decisions on the right side are more accurate than first predicting the lesion diagnosis and then inferring the management. And on the right side, we have the ROC curve, where the blue curve is for the predicted management decisions, and we see that it's much more accurate. The area under the curve is much larger. Similarly, when we look at agreement measures, we see that Cohen's kappa and Fleece kappa. For Cohen's kappa, the model dermatologist agreement is more than the interdermatologist agreement, as we see the numbers here. And for the Fleece kappa, the numbers are comparable. So we can say that the model's predictions agree with dermatologists at least as much as they agree amongst each other. So to conclude, we showed that predicting management decisions directly may be more accurate for skin cancer, as we validated on two datasets. And as we showed, these model predictions have a high degree of agreement with dermatologists. Here is a gist of our contribution. And thank you for listening. This is our paper. We would love to have your feedback on this.